when we're talking about environment, plastics, products that we use on our face and our hair, these things actually impact our ovarian functionality and push our bodies to get periods early, which actually then impacts an earlier menopause. So the key really, and we were really talking about this and letting your audience know, it's not about the pill. It's about making sure you know why you're taking the pill and what your body's metabolic and cycle and hormonal needs are before you start taking it. And again, I really think it's important to emphasize that what's in contraceptive levels, this chemically changed estrogen and progestin, are strong enough, more potent to tell your body, don't ovulate. This dysregulation of hormones, this is the biggest thing that people tell me. Dr. McNally, I do not feel like myself, and the mood is part of it. Since heart disease is the #1 killer of women, we need to go in and ask for our specific genetic risk markers.
Dr. McNally, I am so excited to have you here today and for the conversation that we're going to have and for you to share your expertise. I think this conversation is so important, making the connection between fertility and menopause. I think it's something that women are just beginning to unlock. And so it's an important conversation to have.
Absolutely. And thank you for having me, because the transition from that fertility window through perimenopause, and many women, as we're discussing it, are perimenopausal when they're going through their fertility journeys. So we're here, we're going to discuss. Let's talk.
Let's do it. There is so much hype right now online. There's conversations about birth control and fertility. Does hormonal contraceptives impact fertility long-term, or is that just simply a misunderstanding?
Such an important thing, because when we're talking about hormonal influence, we've got to go back before then. The number of eggs somebody's born with and their genetic predisposition is already built in. And so by putting someone on a contraceptive level dose, it's really telling our brain and our ovaries, be quiet. This is not what's going to impact your fertility. What impacts your fertility are other factors and your genetics. Things that people don't even think about. When we're talking about environment, plastics, products that we use on our face and our hair, these things actually impact our ovarian functionality and push our bodies to get periods early, which actually then impacts an earlier menopause. So it's multifactorial, but the pill itself, taken one day, does not impact your long-term risk for infertility.
And I'm glad that you cleared that confusion, because there's so much hype online about what's being masked and what's not. Can birth control mask underlying hormonal issues that women don't discover until they're trying to get pregnant?
This question is so timely, because PCOS, now renamed PMOS, polyendocrine metabolic ovarian syndrome. So what happens is that, again, we have these underlying risks. The metabolic piece associated with now PMOS really is what's contributing to our hormonal change, our fertility picture, and our cardiac risk in the future. So does a pill mask it? Yes, if you don't properly diagnose, understand before that pill, that Band-Aid gets put on.
What do you wish women understood before going on or coming off birth control?
We said that one day piece. So whether it's a daily pill, a ring that's for a month, a patch that may be weekly, these are short-term boosts of hormones that tell our bodies and our brains don't ovulate. This in and of itself is not impacting your long-term health. And actually, for some women on this continuous hormones, you actually may have some protection when it comes to ovarian risk and colon risk. So you may actually be decreasing certain cancer risks. So again, shorter term interventions with these contraceptive levels are going to have more health benefits. So the key really, we were really talking about this and letting your audience know, it's not about the pill. It's about making sure you know why you're taking the pill and what your body's metabolic and cycle and hormonal needs are before you start taking it.
That's such an important distinction because I think women assume that their bodies will bounce back hormonally. How long does it take realistically for cycles and hormones to regulate after going off the pill?
So if we talk about the pill, it's effective for 24 hours. So your body's natural communication, the brain to the brain to the ovaries, hypothalamic, pituitary ovaries, that should start kicking in pretty fast because we tell women, take your pill every day. If you miss a pill, take two the next day. So if you're missing more than that, your natural cycles will come back. And again, I really think it's important to emphasize that what's in contraceptive levels, this chemically changed estrogen and progestin, are strong enough, more potent to tell your body, don't ovulate. Hormone therapy and menopause, totally different doses, different reasons why you're taking it.
Mm. Can you have a completely regular cycle and still struggle with fertility?
Indeed. When we're talking about fertility, 30% are attributed to some female biology, 30% for some male factor. So 40% of women and couples live in this unknown fertility aspect, and you may have extremely quote unquote regular 21 to 35 days start to start and still have infertility issues.
I think that's such a huge takeaway because so many women equate regular cycles with optimal fertility.
Yeah, and that is not something that you can just assume.
Mhm. I think a lot of women are told severe PMS is just part of being a woman. At what point does PMS actually become something clinically significant like PMDD?
Women have to listen to their bodies. So hormonal regulations occur. You're going to have a spike in estrogen. It triggers an egg for some women. Then there's a progesterone surge. That progesterone surge is called the luteal phase, is what has more of that impact on mood, that you feel more negative. You are going to feel less energy and have some GI bloating. If you are talking about this in the context of a PMDD, that's about 1 to 5% of women where that luteal phase, that progesterone surge impacts in such a negative way. So a long answer to a short question, there are physiologic changes. If you don't feel good and you notice a cycle, absolutely need to speak to a clinical provider to make sure you're getting the right interventions. And there's many of them actually.
So important because women are conditioned to minimize their suffering, especially around their cycle. How do you distinguish between normal hormonal fluctuations and symptoms that suggest a deeper imbalance?
This is where personalized medicine is everything. So when you start getting your cycles, and the average age in the United States is about 11 and a half, about 100 years ago, it was 14 and a half.
Right.
Lots of changes. So it's about getting to know your body. When that cycle kind of gets it to its groove, you have to realize, are you losing school time? Are you losing work because of pain, bleeding, discomfort? Not only the physical symptoms, but also the emotional and mental piece to this. So if it is affecting your life and it's devolving, if you will, you have to speak up.
I think that's where women start questioning themselves instead of questioning whether something physiologically is off. How often are mood symptoms dismissed instead of investigating them hormonally?
Mood is one of those things that we have more work to do to make sure that we're opening that conversation. So at least in New York State, we actually now, for every person going through a medical office, screen for depression. This is an opening gateway for us to have a discussion from a clinical perspective with patients. And we know there are hormonal changes that do affect our mood, but by minimizing it or not encouraging or opening the door for patients to talk about it, that's where the first opportunity is. The second is that it has to be destigmatized because hormonal changes can affect mood. This occurs during our fertility window, well into perimenopause, where actually women that have underlying anxiety and depression for their life have an increase from, say, 40 to 50% to 70% in perimenopause. This dysregulation of hormones, this is the biggest thing that people tell me. Dr. McNally, I do not feel like myself, and the mood is part of it. So, globally, hormonal changes do affect how we feel. Serotonin, dopamine, it has to be discussed, knowing that that's a part of it, and then layering on interventions, whether it's cognitive interventions, therapy, talk therapy, medications. It has to be composite for what that woman needs.
That's such an important point because many women are pushed into mental health treatment without anyone looking deeper hormonally. Let's talk about luteal phase. The luteal phase is becoming part of the fertility conversation online. How important is it actually?
So, your luteal phase is that post ovulation. And now some women have metabolic things that are preventing that regular cadence. PMOS is one of them. But that luteal phase, that progesterone surge, think of progesterone like your protector. That's what tells the uterine lining, be cool, stay there, because there is implantation that helps the environment of the uterus. When the luteal phase is not able to produce enough progesterone, that can impact fertility and implantation. Some women actually report some irregular spotting before their cycle. That's one of those clinical signs that we should start to cue in on. And then, of course, we've got this physical, the fertility piece, but also the luteal phase does cause mood changes, does impact our smooth muscle, which lines our entire intestines. So bloating, discomfort, very much tied to that progesterone surge. So we need it for fertility. We also have some downstream things that make us feel not as great. Some of those food cravings also tied to that surge.
Such an important part of the conversation, the second half of the cycle, and women are just starting to understand it. Can luteal phase issues impact implantation or fertility outcomes?
Yeah, for the luteal phase, if you're not getting that significant progesterone surge, can actually create an environment in the uterus that is not going to equate to a successful implantation. So, tracking those levels and staying connected with your clinical team, especially if you're in the fertility frame, is really important. And what's also interesting when women's cycles are different, start to start, we say the textbook says 21 to 35 days. So there's a variation in the secretory, that pre ovulation piece, but the luteal phase, that second half post ovulation, is pretty consistent. So if you notice those emotional, physical changes, definitely have to look into it.
So it's not just about ovulation, it's about also your body being hormonally preparing for implantation. What are signs a woman may have low progesterone or luteal phase dysfunction?
One of the most common things with that luteal phase change could be some irregular spotting, very light before their real cycle, that normal heavier flow comes. The difficulty getting pregnant can also potentially be tied to it, which is why a collaboration with the right team is really important.
Now, shifting gears into perimenopause. When does perimenopause actually start for most women? And I think this is going to shock most people.
So for perimenopause, it could start as early as your 30s. When we're talking about this perimenopausal transition, there's very good numbers in terms of, we know the average age of menopause in the US is 51.4. But for the transition period of how long it takes you to get there, that's very varied. And what's also maybe very interesting to your listeners is that different backgrounds have different times of length and symptomatology. So for women of an Asian background, you may have 4 years of symptoms, while Latina and African American women may have up to 10 years of symptoms. These are more stereotypically checked with the vasomotor, the hot flash, but the variations in symptoms, the time, the start, the genetic predisposition, because we know an earlier cycle start is equal to an earlier menopause. We could go on, but to break it down, those women that have a perimenopausal transition can vary, and I cannot pinpoint when it will start for each woman.
Such an important distinction you made because I think people still distinguish perimenopause as in later stages of life. How does that impact women who are still trying to conceive?
So the perimenopausal period, because it varies, is really going to be tied to their egg, not just only the quantity, but the quality. So in the fertility space, we check an AMH, an anti-Müllerian hormone level. That does not tell me or you the exact quality of the egg. And in perimenopause, it's going to vary. So we know that there's an egg decline in quality around the age of 35. But for women on their trajectory for an early perimenopausal, menopausal transition, that decline will start earlier, and it's somewhat unpredictable.
What does perimenopause actually feel like on a day-to-day basis?
Perimenopause, for anybody that's in it, it's going to totally vary and depend on what's happening. One of the more common things people are going to report is more breast tenderness. I don't feel like myself. That's that luteal phase shift, that delay in an ovulation cycle. Sometimes headaches are more prominent. We use bleeding patterns as one of the other signals, but it's a total hormonal impact from mind and body. What do I mean by cycle changing? So your cycles tend to get closer together like an accordion and then space out. So if you start to notice some of these changes, that's a time to raise your hand and say, where am I at? And then when and if you've ever had your first hot flash, I remember mine to the T. It is undeniable.
I think that's the part women rarely hear explained clearly. And that creates also such an emotional disconnect that they feel different, but they just can't explain or identify why. When someone is in perimenopause, do you start hormone therapy or HT early, or is it something that you wait on?
This is one of the most impactful questions and an important part. So with individualized medicine, HT should be talked about in the context of hormonal regulation. Women don't feel like themselves because their hormones are starting to shift. The eggs are not necessarily producing as much. And this variation is what you're feeling, even though your cycles may be normal, quote unquote. When we're talking in this perimenopausal period, some women are still in that time frame that they could conceive. So do you bring to the table a discussion about a contraceptive level, which will tell their ovaries, don't do anything, be quiet, but we're going to give you a hormonal steady state with this exogenous higher dose of hormones? Or do we talk about the HT, which is a lower dose of hormones, but does not give a quieting of the periods? It does not give you that contraceptive level. Let me reframe that. So hormone therapy can be given for perimenopausal women, but it does not shut down your ovarian function. So it's more about symptoms, but it will not stop irregular bleeding. That's a big misconception. And it may not solve all of the issues that you're having and definitely not give you hormonal contraceptive protection.
So it's a long-term health conversation, no doubt.
Absolutely. So the take homes from hormonal dosing for contraceptive levels versus not, hormonal doses in perimenopause that are going to give you protection from pregnancy, that are going to stop irregular bleeding, are more likely tied to the standard birth control pill dose. And HT is going to be more related to systemic symptoms. It will not fix bleeding patterns and it will not prevent pregnancy.
There's a growing conversation around HT and cardiovascular protection for women. What does the current evidence actually show?
So when it comes to HT, hormonal therapy is not prescriptive for prevention of heart disease. That is a big misconception. When we're doing a retrospective, which means looking back analysis from the Women's Health Initiative, the doses that they were using were oral for estrogen and progestogen. And in the early menopausal transition, that first 10 years, women who were on estrogen alone had better cardiac outcomes. Women who are on estrogen and progesterone also had a decreased risk of cardiac complications and all-cause mortality in both groups. This is where the data has been looked at retrospectively. The bioidentical doses, the transdermal, the patches, the creams, the gels, we have not prospectively studied. So it's not prescribed for heart prevention, but more literature needs to come out, more research. So stay tuned.
Interesting. How has the conversation around HT shifted in the last decade?
In the last 2 decades plus, HT, no way. Now HT, green light, go.
Woohoo.
Exactly. And that really was an evolution of looking back at the data and saying, maybe we should not put research in the same space of a 50-year-old who's just in that menopausal transition in the same bucket as somebody who's closer to 80. So the time in which the hormone therapy studies were done with the WHI, the average age was 64. Correct. So still a decade past of where many of us do go into menopause. So it is about reframing, restudying, and saying, yes, have that conversation.
It's interesting how one era of research shaped an entire generation of fear around hormones. Is there a window where hormone therapy is most protective or beneficial?
We're still parsing that out because, again, we are using different doses, different modalities in that initial WHI study. So I can't tell you, start this dose on this day to help with bones. We're not there yet, but that is an evolution in research. We do see trends, especially for women put into surgical menopause, that given hormone therapy immediately after surgery or in a short time interval, it will be protective for their heart, their bones, and for their cognition. But how that translates to somebody going through a natural menopause, more information has to be collected.
What happens long-term when women lose estrogen support and don't replace it?
So because we've gone several decades where women have been estrogen depleted for, unfortunately, many decades, we're just trying to learn, again, the dose, the timing of when to add back estrogen in the right patient. So personalizing the journey in this space is exactly where we need to be, having conversations. So where and when to start hormone therapy, we know the guidelines now say to start within 10 years of that menopausal transition. This is the Menopause Society exactly guidelines. If you're less than 60, also a conversation. But when we're starting hormone therapy, it depends on, again, the dose, the modality. When we're looking at cardiac risk, this should be addressed before you're starting something. Understanding your genetic predispositions to different types of cancers, your breast health, putting that all together. So that's where we have to focus our attention now until more studies come out.
Weight changes are one of the biggest frustrations women experience hormonally. Why does fat loss become so much harder during perimenopause and menopause?
How come we get our meno belly, if I translate that question?
Exactly.
It is related to metabolism changes and estrogen as part of the core. So what happens is as estrogen declines, receptors change. And our hormone that makes us feel full goes down. Our hormone that makes us want to eat goes up. And so our body's desire to eat changes. And as the estrogen, again, has gone down, our body looks for other places to put it, which tends to be in our belly area, more visceral fat. And on top of that, as the metabolism is shifting, it's a composite piece to all of those things. Now, will estrogen alone fix this? No. It's about looking at it holistically. And this is not an easy lift for women, but it is time. It is metabolism that really is the driving force.
That is so validating for women because they feel their bodies are changing overnight and they blame themselves. Can insulin resistance and metabolic dysfunction start showing up earlier than women realize?
The big answer is yes. And that's why this slow creep, I like to call it. Oh, I gained a pound or two. I gained a pound or two. And then all of a sudden you're working hard. You've changed your diet, exercise, nutrition, and the scale isn't budging. This is really related to that metabolic slowdown.
Mm-hmm.
And so, yes, there is a real change, and the insulin component to it is real.
Mm-hmm. And it's so much bigger than weight. It's also about inflammation, cardiovascular health. All of it is interconnected. I also think a lot of women normalize things like fatigue, anxiety, and brain fog. At what point do these stop being normal and hormonal red flags?
So, you talked about the triad that is so connected. So, let's go back to sleep. Sleep should be a vital sign.
Mm-hmm.
And how many clinicians are actually asking their patients, how many hours do you sleep? And in the digital space, many of us have rings and watches that help track it. When a woman is going through her perimenopausal, menopausal transition, they're often woken up by a vasomotor symptom. Sometimes they appreciate it, sometimes they don't. Covers on, covers off, covers on, covers off. And so by starting to track how well you are sleeping, that then also drives the daytime fatigue. Ideally 7 to 9 hours. And I know 7 to 9, who has the time for
Right?
that? That is vital. And getting up once to 3 times a night as a woman is normal, but going back to sleep within 10 to 15 minutes is expected as part of that normal circadian change. If this is not happening, you need to bring that up. So, not sleeping triggers a daytime fatigue. There is a lot of data to show that there is a decline in some word recall, the quickness in which we can get those words out in the perimenopausal transition. There is a bounce back to that. And then kind of going back to the day, if you're fatigued, are you eating the right foods that will not crash you and wake you up at night? That mid-afternoon caffeine, the high sugary content foods, high carb dinners, these are things plus, yes, wine, which has a higher sugar intake, will crash at 2 o'clock in the morning, 3 o'clock, and wake you up. So it's all cyclically connected from what you do during the day. So start targeting that nighttime or afternoon caffeine, food, see if that helps with your sleep, and then really bring up your sleep patterns, because there are interventions, not just medications, that will help, and that tends to help the fatigue. Also, which we can't just dismiss, there are physiologic things happening, deficiencies, thyroid hormonal changes that need to be treated and treated. So don't just blame it on perimenopause. Look for other sources and dig deeper with your clinical team.
I'm so glad you elaborated on that, because women are normalizing exhaustion nowadays and trying to operate at high levels, and they don't realize that their hormones can interplay and signal something. How often are women treated for anxiety or depression when the root cause is hormonal?
Probably more than we like. The
Mhm.
fact that we're actually talking about anxiety and depression, because it affects women disproportionately than men, is a
Mhm.
good start. And actually, some medications for the behavioral health space have excellent intervention when it comes to decreasing hot flashes
Mhm.
and without affecting weight or sexual health and libido. So being on these medications actually is protective. I'm sure your listeners may not be aware that the first FDA medication approved for hot flashes is an SSRI. So to that point, the interconnection of your brain receptors, your neurochemistry, and those triggers for other symptoms are very much connected. So being on medications for anxiety, depression actually may have some downstream benefits.
I don't think we often talk about the emotional side of this. Mental health is separated from hormonal health. Why is that?
Because people are afraid to talk about it. That's one of the biggest things, that as your serotonin and dopamine decreases, you are going to have that connected to as your cycle is changing. Estrogen controls a lot of the receptors, the way that those neurochemicals are processed, so you can't separate it out. And the stigma around mental health we will continue to push. And then even if we discuss it, sometimes people then get to a point, well, you have something that needs treatment. Where do you go? What do I do? So it's about education, dialogue, empowerment, and knowing that neurochemistry is connected to ovarian chemistry.
I'm so glad that you brought nuance to this, because women are often taught that it's just something in their head and they have to tolerate it. So millions of women are struggling with symptoms, but only a small percentage are getting treatment. Why is this?
Part of it is the access that now we're talking about it. We have to create more channels. This is exactly what we're doing at our Katz Institute for Women's Health at Northwell. We are creating more capacity. We have the first bricks and mortar out in Stony Brook. That's part of our Center for Menopause and Midlife Health. So we are hearing you, women. We know what you need, and we are trying to meet you where you are. So the access piece is one. And breaking the black box warning. It tells women, stop. Do not take this medication because it will cause heart disease, heart attacks, blood clots, breast cancer. Well, that black box warning was removed this year because not everybody should be told you cannot be on systemic hormone. This will start to move that percentage to a higher percentage for access. We use all of these great media people that are writing books to then provide that excellent clinical care and set up the research, set up the data, set up the standards to get women what they need. The other thing is, you've all heard that there's a national shortage of estrogen patches. It is changing. We are getting what we deserve. So the number's going up.
Woohoo.
Up, 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 up.
Wonderful. It's so encouraging to hear that institutions like Katz are actually taking a more comprehensive approach to women's health. Let's do some rapid fire.
Love it.
IVF accelerates menopause. Myth or fact?
It is a myth. We are predispositioned to where our fertility journey will be. So menopause is not that association with fertility. When it comes to infertility, women who have a difficult time may have some egg quality and quantity issues that are predispositioned. So they may go into an earlier menopause, but it's not the IVF treatment that does it. It's probably their genetics.
One fertility myth you want to debunk?
Fertility myth that I want to debunk is that it will not increase risk of cancer.
One test every woman should ask for, but doesn't.
Every woman should ask for a cardiac risk assessment. New guidelines are coming up where we should screen our daughters and nieces at an earlier age. So what many women don't ask for are genetic blood work testing for their cardiac risk. Since heart disease is the #1 killer of women, we need to go in and ask for our specific genetic risk markers.
One symptom women should never ignore.
They should never ignore chest pain. It is not just anxiety. Perimenopausal symptoms of hot flashes can cause palpitations, but this is one that you should never ignore.
Best thing a woman in her 30s can do today?
Say no. What do I mean by that? You have to prioritize your health earlier on. And it is the yes, 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 go, go, go. And to take a small amount of time. I wish I did that in my 30s because it sets us up for our success in the future.
One thing you wish a woman understood about her hormones?
That they fluctuate. That a blood test with one point in time does not give a holistic approach. So don't ask just for a static blood level. Things change from day to day. And it's not just your ovaries that are affecting you. It is your brain hormones. It's your stress hormones. It's all connected.
One thing you wish you'd do differently if you were 35 today?
Again, take care of myself.
Yeah. Now, because this podcast is about dismantling limiting beliefs, what's one belief you personally had to unlearn in your life or career?
It's the hormone therapy. we were taught in medical school the dangers of hormone therapy, that this is something that you cannot give women. If you went back to myself then and told me I would be putting patients with breast cancer on hormonal therapy, I would never believe you. This is absolutely amazing and is literally going to revolutionize not only generalized women's healthcare, but how we specifically deal with women and interact and treat them and listen to them for those that have gone through cancer. So our survivors out there, a whole new world.
What does self-care realistically look for you right now?
Well, as you can see by my Barbie pink nails, my self-care getting into my next decade is a little bit of me time.
Good for you.
It is about reprioritizing my health. And I did, starting this big birthday year, go to the gym. I have a trainer, which I'm very privileged to be able to do that. But even if you don't have access to that, what are some home hacks that you can do to create time for yourself, that you can create some time for some exercise, or even just 2 minutes a day to breathe?
Love that. So many listeners are going to be able to relate to that. So tell us, where can listeners contact you and find out more about your work?
I'm very active on social media, so they can find me at Steph T. McNally, MD. I work so collaboratively with Northwell and our Katz Institute for Women's Health, The Well, which pushes out content on Instagram, TikTok. And from a professional standpoint, we do so much education for the community. There are lots of events that myself and our team do. When it comes to continuing medical education, we are embedding curriculum in our medical school, to our residents, fellows, to our attendings, and globally.
I feel like this conversation connected the dots for women, especially on so many topics that are rarely discussed altogether: fertility, perimenopause, menopause, anxiety, mental health. Thank you so much, Dr. McNally, for bringing both the medical perspective and the human perspective to this conversation today.
Thank you so much. This was an absolute pleasure.